Hi, I'm Douglas Goldstein, innovator and e-futurist, and I'm with Health Innovation Media. And we've got Murray Brozinsky, who's the Chief Strategy Officer of Healthline. And Healthline had a really big announcement at Health 2.0 yesterday about Health Data Engine. Is that what it is?
We did.
What does this engine do, and where can we go with it?
So it's very revolutionary. So we've launched this. It's a whole platform for accessing data that's currently inaccessible, so data that's caught up in unstructured formats. So physician notes and progress notes and hospital admission notes, where all the narrative and all the valuable information about patients is locked up, and up until having this health data engine is really not usable in applications around providing better care for patients. So we're super excited. I'll give you examples of some of the applications that we've launched.
All right, so let me understand though, unstructured data. Some people I think call it thick data, but it's unstructured. How do you get, it's in all the EMRs, right? Or it's in dictation notes. So how do you get it out of that to make it useful?
Yeah, very good point. So people don't know this because the EMRs were designed to capture information predominantly for reporting. They do a great job, but 80% of the information is in what we call unstructured. It's the way that people actually capture information. They talk, they interview, they transcribe dictation notes, and all that information, you're right, is digitized in the EMR. So what we do is we use really advanced natural language processing and taxonomies and clinical rules, really advanced technology to go through and understand what that narrative is all about. And so, for example, we launched our first application is a risk application to reduce readmission rates, hospital readmission rates for heart failure patients. So lots of predictive models have been designed. We know what the factors are that predict whether someone will be coming back in for complications, but a lot of those factors are socio-environmental factors. Are you living alone? Are you depressed? Are you homeless? All those sorts of things. None of that stuff is coded for in an EMR. So our technology can go through the clinical coded stuff, then go through the unstructured, find all those factors, also find factors like, are you hypertensive, have you been in the hospital before for heart failure where it may have been miscoded, take all that stuff and then find those patients that are at high risk. So the first step in any intervention is, let me make sure I'm focusing on the right patients.
So that is really, really huge, because I'm a very big advocate of that many things that can help people feel better and have a healthier life and reduce costs have nothing to do with health. It doesn't have to do with the text message. It has to do with those social and contextual factors. So maybe help, I think, a little expansion of your spin and your approach to that, because I think that most people at Health 2.0 and other places don't really grasp that, because we're sitting here with the wholesale mindset and we're moving to a retail industry.
Yeah, so let me give you by way of analogy. So we're solving what's called the Wanamaker problem. So John Wanamaker, who was a big department store magnate at the turn of the century, said that he spent half of his advertising dollars on the wrong customers. He just didn't know which half. So we know what the interventions are for heart failure, for example. They're very well defined for very specific types of patients. So if you're a homeless person with a methamphetamine-induced heart failure, you have a very different risk profile and very different interventions a doctor would take than if you were a typical elderly person with a really good family support system. So what we're doing is basically saying the interventions are well known. If you knew the profile of the patients, the information is readily available in all of this documentation. The nurses are doing really good interviews when you come to the hospital. All we're doing is saying, give us the predictive factors we know about. They're very well documented. People have built predictive models, but how can you find those patients so that you can provide the right intervention? So to your point, a lot of it has nothing to do with the clinical part of health. It's all those socio-environmental factors. Are you under financial distress? But also, importantly, the clinical factors, if they're not coded for, they're miscoded, and there's lots of errors, our technology goes through in a very sophisticated way and says, let's find evidence in the narrative to suggest those factors are truly there, and then let's weight those appropriately and use those to put people in the right bucket so the right interventions are targeted toward them.
So how do people let you have this data? I mean, did you have to go to every hospital in the country, or how do you access all this unstructured data?
It's a really great question. So right now, people recognize that the value, the information is there and they can't get it, so they're raising their hand. We're getting hospitals coming to us and practices coming to us saying, can we incorporate this engine into our systems? And now we're also, so in the long run, and we're right now piloting, we just launched an early adopter program. So we're working directly with large integrated delivery networks and systems, but we're also working with EMRs, and we're going to, ultimately, this engine will be integrated in every EMR and in every analytics and predictive modeling package out there.
So the leading health systems in the country and the leaders that you're working with get that we really have to start understanding the social and cultural context that we're providing care to both individuals and groups of people in zip codes or communities or neighborhoods. Is that accurate? Do I understand it correctly?
Yeah, that's one portion. They're understanding there's all sorts of information, a lot of it the socio-environmental and the socioeconomic factors. And then in addition to that, they recognize there's a lot of clinical information in the unstructured nodes that can provide context around the clinical information that's coded. It's sort of like if our health data engine were to read Harry Potter, right, and figure out, if you read it, it's nice, it's all this sort of data, but there's enough evidence in there to suggest he has nummular headaches, right? You would never know that. It says it never even talks about the specific symptoms, but enough evidence can be pieced together like a jigsaw puzzle with this engine to make that conclusion. So the health systems are saying, we know 80% of the information is unstructured and there's valuable nuggets in there, and we need to be able to bring that into structured form so we can use it to drive our model. And by the way, this is part of a trend that right now EMRs, which are wonderful, $30 billion from the government to get electronic records, to collect all this information and digitize it, is descriptive. Now we know the profiles of all these patients and what they have. We're trying to move ourselves into the world of predictive, where we can kind of intervene earlier. I know that you're likely to have diabetes in 2 years. Let me intervene. You'll have a better life, better health outcomes, much lower cost.
Right. So that reminds me. So let's take hip and knee replacement, right? I mean, Medicare, the government, us as taxpayers are going to be on the line for perhaps 2 hip and knee replacements because people are getting, half of them are people under 65 right now. So then they're going to get a second one when they're 80, when there could be a lot. So if we knew at the earliest onset of osteoarthritis, for instance, so that's the same kind of analogy that you're talking about.
That's exactly right. That's the promise of population health, which is how do I understand my population, put them into cohorts, and then intervene earlier. And it could be intervene before the onset of a condition or a disease, or it could be intervene before it progresses, or it could be intervene before complications occur after a surgery, or intervene, as in the case of our first application, around patients most likely be readmitted. So there are all of these touch points. Those are 4 that represent a huge cost in the healthcare system today.
So there's good ideas, there's really cool technology, and then people have these pilots, and but we don't see a lot of outcomes. So you said you have an early adopters program now, so you must have done something with some set of people to have some initial outcomes that allow you to persuade people to come into the early adopter program. So you can talk about the initial outcomes you saw from the early applications of the health data engine?
Sure. So HealthLine's been around for a while, and the technology, we have other products, and so the technology underlying the health data engine is already implemented and been proven out in other applications. So we use what's called a content analytics matching engine. So right now we're involved with IBM Watson, for example, so we'll take patient profiles and very, very accurately match it to the right set of content or treatment recommendations in the case of Watson. Reed Elsevier is using it to underlie their clinical key product, which again is the provider at the point of care, takes the profile of a patient, can access the right information and match it. So the technology is proven, and then what we've done is we've gone out and we've proven that we can identify the right cohorts, right? So we can risk score the patients, that's been proven. We haven't yet, this is why we're doing the early adopter program, showing people if then they take those patient cohorts and do the appropriate interventions, then they'll actually reduce readmission. So that's the next metric we're going to try to impact.
But do you have some preliminary indications that it will work? Have you done projections about the outcomes of this based on that data?
Oh, absolutely. So in a lot of different areas, incorporating the unstructured information, we can show in different applications, and advisory board and others have done research on this, what the impact will be on reducing readmissions for heart failure specifically. We think we probably can reduce the amount of time a clinician or care manager spends on reviewing the chart by maybe 50%. We think we can get the care team immediately to focus on high value activities because they're focusing on the high risk patients, and we're hoping to reduce readmissions by 20 to 30%.
Okay, so that's basically the value proposition with those predictions and those estimates. That's what you're going out, and the early adopters are saying, yeah, we're going to work with you to demonstrate whether that's better or worse on how we execute this.
That's exactly right, with one caveat. Again, our technology is really, really good at saying, so here's the way this application works. Upload your predictive model. We're not telling you what factors are predictive. A lot of smarter people than us have already done the predictive models. The interventions, when you know who the right patients are, so once you put the patients into the right cohorts and know what their risk factors are and how they're profiled, choosing the right interventions, the right guidelines, the right care plans. A lot of smart people have developed those. We're basically saying we will find you the right patients that match those predictive models and match them to the right intervention. So the caveat is we'll find the right patients. We can prove we can do that. The hospital still needs to take the right interventions.
So the health systems and the hospitals and the group practice and the physician leaders have to execute smart, right?
Yeah, and as you heard in the panel we just talked about, I'm not one of those that believes that technology is going to replace the doctors. I think it's going to help the doctors and the nurses and all the healthcare professionals. It's going to leverage what they do really well, which is work directly with the patient. So we're going to say, stop wasting your time with the wrong patients. Focus on those that are really at high risk, that are going to benefit from your expertise, but the burden is still on the healthcare community and the people to do what they do best.
Right, so as it relates to Watson, I understand that Watson beats human in Jeopardy, but human plus Watson beat Watson. So that's the point you're trying to make, right? That technology, whether it's an MRI or these analytic tools, are going to enhance our ability to care for people properly executed.
Right, and I would say two things. I would say healthcare is infinitely more difficult than Jeopardy, and I would say that Healthline plus human beats all of the above.
Okay, great. Thanks. Hey, Murray, thanks for sharing your insights for Health Innovation Media, and have a great rest of the show.
Wonderful. Thanks for having me.
Thanks.